about the other mic? That's the room mic, I think. So one's the recording mic and one's the room mic. I think we should do the room mic.
Okay, let's do it. Sure. That sounds great. Absolutely. However you want to wire me up here.
Put on a tag anywhere really fast.
How's that?
And press the hold off. Press the hold off. Momentary, if it turns orange, that's a mute.
It's off. Perfect. And this one's on, ready to roll?
Yes.
Okay, sounds great. I'll just leave that down if that's okay.
Yeah.
Cool. Sounds good.
Before we get started, let me unofficially say lunch has been ordered. We're not sure what the glitch is. I spoke with Dr. Brown. We're going to get started, and you're welcome to get up and get it when it gets here. They are trying to figure out what the problem is. I know our first rounds we had upstairs, so we wanted to make sure that the location hasn't changed. Really not sure where the problem is, but we're going to get started, just in interest of time, if that's okay. Okay? When lunch is here, just quietly, without disturbing the group, please get up and make sure we'll do that. If that's okay. I'll announce the brain rounds and stuff, because I know people view from. So, welcome to Pediatric Grand Rounds. I think we are just starting off our fall session and are very, very excited to have Dr. Seth Brown here with us today to give us a wonderful jump start. I'm Dr. Jay Shankar. I'm one of the general pediatricians in the Department of Pediatrics. Before we get started, just a few housekeeping items. We are distributing the evaluation form as well as how to sign on for credit, and we need every one of you in the room to please do so. Even if you don't need credit, if you would call that number and sign on, because that's how we also count our attendance for grand rounds. So even medical students, everybody, if this is the first time you're doing that, you will get a text back from the CME office trying to identify who that phone number belongs to in the next week or so, and then you can respond to it, and from there on, you will be signed on with the Department of CME. Also, our evaluations are vital for us to be able to continue this as a program, so please, at the end of the session, don't forget to do your evaluations and turn them in. Again, like I said, it's my pleasure to invite Dr. Brown here today. I'm very excited to hear his talk. Dr. Brown, I can say, is truly one of our own. He did his undergraduate here at ETSU, went on to do his medical schooling at ETSU, and I think I remember him from back then, following which he did his pediatric residency through the South Carolina Greenville Health System. Along the way, he has won many, many accolades. I saw on his CV that he had what was called the Miracle Maker Award given to him in Greenville, which was given to the most outstanding graduating pediatric resident. Of course, his CV is full of most outstanding inpatient pediatrics residents, Stellar Star Award, Pediatric Resident Teaching Award. I mean, it's just replete with all kinds of honors and awards. Following his residency in Greenville, he went on to do a pediatric fellowship in emergency medicine in Louisville, and has had several publications, suture demonstrations, and trauma seminars that he has conducted there. We are truly fortunate to have him working as one of our pediatric ER folks, and I know the residents love to work with him. So again, welcome, Dr. Brown.
Thank you. All right. Good to see you guys. I know most of you all, if you don't know me, you at least know my voice from calling admissions up. Sorry. But anyway, that's what we do in the ER, right? So today I wanted to focus on the critically ill congenital heart disease patient and how they present initially to the pediatric ER, but this is also very important wherever you end up working, because this exact same presentation could come into your general peds clinic, tertiary ER in Norton, Virginia, Dickinson. Very, very important patient population to be familiar with. Unfortunately, I have nothing to disclose financially. Our objectives today are to discuss the tools necessary for identifying and initially managing undifferentiated, decompensated congenital heart disease in the ED. Now, where we aren't going today, we're not going to do an in-depth review of the anatomy and physiology of every possible congenital heart defect. A, I'm not the expert for that, and B, we just don't have the time. But it's, like I said, we wanted to definitely focus on the initial presentation. So let's go ahead and start off with a case. It's 3:30 in the morning, and you have a 6-week-old female who presents with lethargy, poor feeding, and respiratory distress. 2 days prior, the child developed a cough, runny nose, and subsequently some emesis. After the 2 a.m. feed, though, things really tanked. So she developed respiratory distress that worsened dramatically, and she was much more lethargic after 2 a.m. So what do the parents do? They live in Southwest Virginia, so they get in the car. They don't call an ambulance. They just put them in the car, 2 o'clock in the morning, and they drive an hour and a half, and they plop in your ER triage. So on a little further history, she's a product of a G3P2 full-term, uncomplicated pregnancy. And delivery was unremarkable, except for a little bit of mech staining in the fluid, but did not require any vigorous stimulation or any endotracheal intubation or suctioning. Didn't have to go to the NICU, but unfortunately, pediatric follow-up has been poor. So on your physical exam, she's a little cool, 96.4 rectally. She's tachypnic at 72. Her pressure's okay, 92/68, heart rate's 160, and SATs are holding at 98%. She's mildly cachectic, acyanotic, pale, lethargic, and tachypnic. HENT exam really doesn't give you a lot of help in terms of coming up with a diagnosis. But when you listen to the lungs, there's scattered crackles, decreased aeration in the left lower lobe, subcostal and intercostal retraction, so she's definitely in distress. Cardiac exam, regular rate and rhythm, but there's a 2 out of 6 harsh systolic ejection murmur heard at the left lower sternal border. S1's normal, S2 is prominent, and there's actually an S4 that's also noted on your physical exam. So moving on to the abdominal exam, the abdomen is soft, non-distended. Liver edge is palpable about 3 to 4 centimeters down below the right costal margin. Extremities are not reassuring, cool. Central pulses are strong, but the peripheral pulses are moderate at best. You do not notice any radiofemoral delay, but look at the cap refill, 4 seconds. It's pretty cruddy, right? So let's talk about a differential diagnosis other than the title of my presentation. So medical students in the room? Sheepishly raise your hand. Go ahead. All right. So let's talk about a differential in this. Let's start with the medical students, and then we'll move on to the PGY1s and on up. So what do you think? What else is on the differential other than congenital heart defect in this kid? Say it loud. Say it proud. I'm sorry? CHF? Okay, great. What else? Say it loud. Pneumonia, so primary pulmonary process. Great. PGY1s? Bueller, anyone?
Metabolic disorder.
Great, excellent one. Metabolic disorder. What else? We can move on up to the 2s and 3s now. Wonderful. So a critically ill neonate is septic until proven otherwise. Okay. Anything else at all? Good. What else? These are all great. So those are all excellent additions. So what I remember is the mnemonic, the Misfits. So anytime you have a critically ill neonate, you think about trauma, be it non-accidental or accidental. Endocrine issues, so CAH, thyrotoxicosis, metabolic problems. I think someone said metabolism, maybe Adam. So specifically low calcium and low glucose. So in the neonatal population, these are the 2 electrolytes that'll kill you. And you have to get on them and diagnose and treat quickly. Inborn errors of metabolism, sepsis, good job, Aaron. Formula dilution. So quite frequently, parents will try to make the budget stretch a little further. And when you talk about the actual mixing history in terms of formula, they typically will mix a little too dilute, and you end up having hyponatremic issues. Obviously, you can have too thick of solution as well. But formula dilution issues is an issue. Intestinal catastrophes. So don't forget neck. Obviously, it's a NICU problem, but it can still happen in the neonatal time period. Volvulus intussusception, so all those things that Dr. Taylor needs to help us out with. Toxins and seizures, okay? Now, I will tell you that my last very ill neonate that came in through the ER was a combination of toxins, seizures, and hypoglycemia as well. So that was definitely an interesting case that took a little while to work through. Now, do we know why this isn't presenting on the top there? Okay, we'll keep moving. So in general, there are three broad categories of critical congenital cardiac lesions. I think about left-sided obstructive ductal dependent lesions, right-sided obstructive ductal dependent lesions, and then shunting or mixing lesions, okay? So I like to kind of get it down as basic as possible. So these are three broad categories when you're talking about critical congenital heart lesions. Now, if you remember nothing else from today, remember that physiology is age dependent, okay? So age at presentation is one of the most important variables to consider. Okay? All right, so let's go back prenatally. So intrauterine, we have what's called the ductus arteriosus. So this is a conduit between the PA and the aorta. And then we also have the foramen ovale, which is patent during prenatal time as well. So these are your two blood flow pathways, so to speak, during intrauterine life. Now, infants who present early, remember I told you the age is very, very important here. Infants who present early, usually within that first month of life, is most likely to have a ductal dependent lesion. So these can either be cyanotic from an obstructive right heart lesion or profoundly hypoperfused from an obstructive left heart lesion. And after that 1 month of age period, infants are most likely to present in respiratory distress or CHF caused by a left or right shunt. So what do we have in terms of our toolkit in the PEDS ED in trying to figure out exactly what's going on with these kids? So we're going to talk about the hyperoxia test. Who's heard of the hyperoxia test? A few hands here and there. Also going to talk about, we've got our history and physical, right? So asking about weight gain. How's the weight gain been since coming home from the newborn nursery? Murmurs, hepatomegaly, brachiofemoral pulse differentials. Those are all tools in our toolkit. Now, let's look at the blood pressure. So if you have a right upper and lower extremity blood pressure differential of greater than 10 millimeters of mercury, that's concerning for the possibility of a congenital heart defect. If you move on to the pulse oximetry and you have a differential of greater than 3% or less than 94% in the lower extremity or less than 90% in any extremity, that's also concerning for a congenital heart defect. And then we also have EKGs, chest x-rays, BNP, as well as the BLEEP. We'll talk about BLEEP here in just a second. So these are all tools in your toolkit that are readily accessible in the pediatric ED, and you can have a majority of these things done within the first, I'd say, 5 minutes that they come into the resuscitation bay. Okay, let's take a break and talk about epi real quickly. So unfortunately, the true incidence of congenital heart defects is difficult to determine, basically because there's so much variability in terms of its definition. And a critical CHD lesion is one that requires surgery or intervention to prevent significant morbidity and mortality in the first year of life. And actually, Dr. DeVoe back in 2006 was part of the Tennessee Task Force on screening newborn infants for critical CHD, and his team estimated the incidence to be about 1.7 in 1,000 live births. Excuse me. Now, I'm going to get into some scary statistics here. So among those, nearly 1 in 1,000 was discharged home with a missed critical left heart lesion. So if you look at left obstructive lesions, the most common lesions presenting after discharge are coarc, interruption of the aortic arch, aortic valve stenosis, TAP-VR, or total anomalous pulmonary vein return, or hypoplastic left heart syndrome. So there was actually a study of missed congenital heart lesions, and they found that more than half of those infants with a misdiagnosis of critical CHD died at home or in the ED. Look at this median age of death, 14 days. That's scary. And the most common delayed diagnoses were hypoplastic left heart and a critical comarc. So there was another patient series where only 50% of infants with a congenital heart defect had an abnormal nursery exam finding. When they did have an abnormal exam, it was usually a murmur. But this is crazy. I mean, this is under the radar. These are the newborn nursery babies that feed well for the first couple of days, have no issues with any vital signs instability, and they're dead in 14 days. I mean, this is super scary from an emergency medicine perspective, and as well as a general pediatric perspective as well. So, unfortunately, remember I told you that the left obstructive lesions are the most common ones to present. They're even less likely to be detected during a nursery physical exam. So, additionally, undiagnosed children with critical CHD frequently present to non-tertiary EDs for initial management before transfer. So although it'd be great if they all came to us where we had great specialists, great resources in terms of quick echo, we know where they land, right? They land in Johnson County, they land in Dickinson, they land in Norton, right? And without a sign that says, hey, I have a critical congenital heart defect, they come in with a chief complaint of vomiting or chief complaint of lethargy. So it's a tough one. This is literally one of the needles in the haystack that we always have to kind of keep our radar up for. So let's switch gears and talk about pulse ox in the newborn nursery. Back in 2009, the AHA and the AAP published a joint statement noting the potential for pulse ox, basically to improve identification before nursery discharge. And the way that we do screening is you get a pulse ox from the preductal right upper extremity and then a postductal lower extremity O2 sat. So a positive screen is when you have a sat less than 90% in the right upper extremity or either lower extremity, a sat of 94% or less in the right upper extremity and either lower extremity, a sat difference greater than 3% between right upper extremity and the lower extremities. And basically, if you have any one of these, it buys you an echo, or it buys you at least very, very, very close follow-up with cardiology. Now, the critical CHDs that are targeted in pulse ox screening are hypoplastic left, pulmonary atresia, TET, TAP-VR, transposition of the great arteries, tricuspid atresia, and truncus arteriosus. Now that brings us to cyanosis. So cyanosis becomes apparent when the sat drops below about 80%. And one of the key findings that we have to kind of tease out from the parents all the time is central versus acrocyanosis, okay? We see acrocyanosis all the time in the pediatric ER. You see it all the time in the clinic. But you always have to have your radar up for, could this be a missed congenital heart defect? So central cyanosis involves the lips, tongue, and the mucous membranes, whereas acrocyanosis affects the feet, hands, and the circumoral region. So there's something called differential cyanosis where you have lower extremity cyanosis only. That raises your suspicion of either persistent pulmonary hypertension with a right to left shunt, an interrupted aortic arch, and coarctation of the aorta. So remember though too, cyanosis is not just for congenital heart defects. So kids with septic shock can be cyanotic. Obviously cyanotic CHD, persistent pulmonary hypertension, and methemoglobinemia. So question for the residents, so what over-the-counter remedy is a cause of methemoglobinemia? Oragel, excellent, excellent. So there again, very, very important history taking as if they've used any Oragel over the treatment, or over the counter rather. So cyanotic congenital heart defects can be divided into either right-sided obstructive ductal dependent lesions, right outflow tract obstruction that decreases blood flow to the PAs, or mixing lesions. Now, in terms of your presentation, the most sensitive and specific findings for serious congestive heart failure in infants is poor feeding, so less than 3 ounces per feed, taking more than 40 minutes per breastfeed, a respiratory rate greater than 60 or irregular breathing, or a liver edge that was below about 2.5 centimeters below the right costal margin. Now, what was our patient's, how far below the right costal margin was our patient in the presentation? like 3 to 4 centimeters, so definitely abnormal. So just exactly like Aaron said very astutely, a neonate in distress should be presumed septic until proven otherwise. So just because we think it's maybe a congenital heart defect, you're talking about split-second decisions within the first few minutes in the PEDS ED. So empiric antibiotics should be initiated as soon as possible for every critically ill infant. And infants presenting at a younger age, again, the age is really, really important here, they're most likely to have a ductal-dependent lesion. And remember that shunting lesions are more common during later infancy, so age is critical. So let's talk about the hyperoxia test. So basically what you do, you take an ABG at room air, and then you take a second ABG about 10 minutes later after they've received 100% FiO2. So the thought process behind the hyperoxia test is if it's a primary lung problem, the supplemental O2 increases the partial pressure of oxygen in the ABG, so your second ABG should have a O2 content of over 150, okay? Conversely, if the lungs are already doing their job and you give them more oxygen and it doesn't have any effect, then the cyanosis is typically due to a shunting lesion that's bypassing the lung. So that's when you think about a congenital heart defect, okay? So now here's what's difficult about the hyperoxia test. Getting one ABG, not venous, not capillary, ABG is difficult in a critically ill infant, let alone two, okay? A lot of times we struggle just getting IV access on these kids, right? And remember, too, that this is one of the situations where we may do more harm than good. So remember that 100% oxygen is a pulmonary vasodilator and could actually worsen respiratory distress in a patient with a ductal-dependent lesion. So it could cause pulmonary overload, and if you're even thinking about doing any hyperoxia test, you need to always think about starting prostaglandins as well as intubation if needed. But the thing about it is, PEDS boards loves this. So if you've just taken or getting ready to study for PEDS boards, they love the hyperoxia test. All right, so we're going to move on to the physical exam. So always be wary of tachypnea without fever and tachycardia without fever. That was one big part of my PGM training, is to really, really key in on the vital signs. And if you've got a child that's tachycardic for no reason, you got to watch. You got to be very, very careful, because there could be a lot of things going on that could be fatal if you miss it. Same thing with tachypnea. So if you have tachypnea without fever, you have to be very, very cautious. Poor weight gain, so less than 30 grams usually per day. Abnormally diminished or absent femoral pulses. This is usually indicative of aortic narrowing. Prolonged capillary refill time, or a peripheral pulse deficits. Those signify profound hemodynamic collapse consistent with a left obstructive ductal dependent lesion. Now let's talk about murmurs quickly. So 6 cardinal signs of pathologic murmurs. Pansystolic, if the intensity is 3 out of 6 or greater. If the point of maximal intensity is at the left upper sternal border. If it is a harsh quality sounding murmur. If there's an early mid-systolic click. If there's an abnormal heart sound. And in terms of the EKG, we definitely want to pay special attention to axis deviation, AV prolongation, and atrial or ventricular enlargement. Now, remember, though, too, that although we use an EKG as part of our overall workup, you can have a completely stone-cold normal EKG and still have a pretty serious congenital heart defect. So a normal EKG, you can't rest in that at all. And remember that as the neonate, just generally in terms of normal babies, as the neonate transitions into infancy, the axis shifts from a rightward to a normal adult leftward during about the first 6 months of life. Now, right axis deviation suggests either a strong rightward force, or remember, hypoplastic left doesn't have hardly any left force, right? So you can have a lack of leftward force and still have what's called a right axis deviation. So think about hypoplastic left hearts here, right ventricular outflow tract obstructing lesion, so either TET or Epstein's anomaly. If you see an AV block, a lot of times this can be suggestive of an AV canal defect. And left axis deviation can be indicative of either tricuspid atresia or pulmonary atresia. Now, it gets a little bit dicey when you throw a VSD in with these lesions. So it's not 100% in terms of left axis deviation, but at least it's a good rule to start with. Now, remember that whereas right axis deviation is normal at birth, right ventricular hypertrophy is not, okay? And newborns have upright T waves in V1, which invert after the first week of life, and then they don't come back upright until adolescence. Okay, so this is kind of a normal EKG type review here in terms of age variance. Now, we always have to think about RVH and LVH. So in terms of right ventricular hypertrophy, a positive T wave in V1 after 1 week old is consistent with that. Or if you have R in V1 or S in V6 greater than the 98th percentile. So something you need to be carrying with you is the Dagnon normal intervals per age, because they definitely change. And it's something that we refer to on a daily basis with every EKG in the pediatric ED. In terms of LVH, if you have a S in V1 or R in V6 greater than the 98th percentile, that's consistent with the possibility of LVH on ECG. Now let's talk about labs. What labs would you want? You got a crashing kid, you're thinking about calling Dr. Coy here in a little bit, but you need to get some labs, you need to get a little bit of information first. So what do we want? State lab. CBC, I like it. Look, okay, glucose is very good. So CBC, CMP. Now we're mainly looking for anemia on the CBC. When is physiologic nadir for HNH? Around the 10-week mark. What about in Dr. DeVoe's population? Earlier or later? Earlier, around the 6-week portion. So electrolyte derangements, who said glucose? Excellent job. And what was the other one I said to always watch out for? Calcium. So hemoglobin level is also very important. Anything else? Any other labs you want? Blood gas. Excellent, excellent. What else? Cultures. I heard cultures. I'm good with that. How about a lactic acid? pH, you're going to get that on your gas. Ammonia, maybe thinking about inborn errors of metabolism, right? Blood and urine cultures. What other gland can go awry that we need to get labs for? Thyroid, exactly. So TSH and free T4. Thyroid toxicosis you always have to think about. Haven't seen it frequently, but it rolled through the ER when I was in fellowship in Louisville. So in terms of imaging, so your chest x-ray can actually reveal the causes of respiratory distress or shock, as well as aid in the diagnosis of critical congenital heart defects. So remember, cardiomegaly, that's when half of the chest cavity is consumed by the heart. That's an important sign. And remember that some cardiac malformations are associated with classic appearances on chest x-ray. So when you hear classic appearances on chest x-ray, boards loves it, okay? Just think about, when you take your Gen Peds boards, think about any easy picture that they can, it's a no-brainer picture, nobody can even argue what it is. They're going to pull it out and they're going to plop it right in the middle of your boards. And they love these classic cardiac malformations. Now we're going to talk about some x-rays here in just a second, but before we do, let's talk about the BNP, okay? So this is a lab that can be used to differentiate pulmonary from cardiac reasons of respiratory distress. And it depends on who you trust in terms of the literature here. But I remember 100. A cutoff less than 100 for the identification of heart disease has a sensitivity of 100 and a specificity of about 98%. Now again, there's a little bit of variation in that lab depending on which literature you trust here. So moving on to classic x-ray. So let's talk about transposition of the great vessels. So this x-ray has what's called an egg on a string appearance, and this is due to malrotation of the great vessels. So here's a picture of transposition. So you got a schematic on the left, your chest x-ray in the middle, and the kid swallowed an egg for some reason on the right x-ray. All right, so again, these are classic board questions, okay? And they're probably not going to ask you, what is this lesion? They're going to ask you, what's your next step? Okay, so they like to ask two-step questions. So moving on to total anomalous pulmonary vein return. So they have what's called the snowman appearance, and that's due to the input of the pulmonary veins into the right atrium. So schematic in the chest x-ray there. Okay, is that in your brain yet? All right. And so tetralogy of Fallot, we always think about the boot-shaped heart. There's a picture of Tet. And then if they don't come with those nice, beautiful board-worthy chest x-rays, a lot of times you may just have complete whiteout. And you have to think about pulmonary vascular edema consistent with heart failure if you see these x-rays. And those are usually due to left obstructive lesions. So here's a picture of whiteout. Probably quite a few people have already seen this in their training. And then also remember, too, that if there's a blackout appearance, that's also concerning. Because if you have paucity of pulmonary vascular markings, you have to think about some sort of a right obstructive lesion and persistent pulmonary hypertension here. So here's an example of a kind of a blackout chest x-ray. Yay, there's food. All right, so you guys go ahead, feel free, please. I know you're on kind of a schedule, so go ahead and get food as they get it set out. So, if they're stable enough, yes. I think that's an excellent point. Clinically, in the ED, if a crashing kid rolls into room 8, maybe a 1 view is all we've got. But yes, absolutely. You bring up a great point, because even with belly x-rays in the ED, I love 2 views. Quite a few people just get a KUB, but I'm interested in seeing how the gas pattern moves with position changes. Because if I just do a KUB and I don't have any gas past the hepatic flexure, do I have some sort of an obstruction? The easy thing to do is just get an upright film. And then a lot of times on that next film, you'll see the gas go all the way down to the rectum, and it kind of makes you feel a little bit better that maybe you don't have an actual obstruction.
I just brought that up because in some cases of congestive heart failure,
Right.
if posterior deviation of the trachea,
Right.
due to the enlarged heart, you may miss an AP.
That's a great point. So I think the take-home point, especially for the residents, is if you can get 2 views, get it, because it just gives you much better information.
The other thing is that
Yes.
a lot of people can't tell you which chamber it's on.
Very good point.
They don't see
Right. Exactly. And you're talking about a menial amount of extra radiation. A lot of times in the PZD, we're crazy about radiation. We don't scan heads unless we absolutely have to. But in this situation, an X-ray is a pretty small amount of radiation in general, and one more shot can give you a ton more information. Just remember that. All right. So here's a picture of blackout chest X-ray. So let's move on to BLEEP. All right. Anybody ever heard of BLEEP? So ER docs love ultrasound. We loved it in my fellowship in Louisville. A lot of the pediatric emergency medicine research is where can I put an ultrasound probe and what can I learn from it. It's cheap, it's at the bedside, and it's non-ionizing. So that's why we love it in peds. So BLEEP stands for Bedside Limited Echocardiography by the Emergency Physician. Okay, so this gives us very gross information about things like contractility. I can confirm grossly if we have 4 chambers or not. If you look here, we frequently found this in the pediatric ER in Louisville, pericardial effusions. Now, I see Dr. Teixeira starting to sweat back there. Seth's doing ultrasounds in the ED? He's doing echoes? No, totally kidding. I'm not looking for, is the shortening fraction 38% versus 42? Not what we're doing. I'm not looking for the coronary arteries coming off of the correct place. I'm not looking for that at all. I'm looking for, is the heart sitting there doing this, or is it giving good squeeze? Okay? Is there a huge pericardial effusion that may need a needle in the next 15 minutes, or is there not a pericardial effusion? Okay? So again, gross things, but the cool thing about this, you can drop the probe on the kid's chest and you can have this view in about 15 to 30 seconds. I'm sorry? Well, so we have one ultrasound machine for the entire ED. So it's usually parked over on the adult side. But yeah, I have used it, definitely have. In an arrest situation, I've used it. Another great time where we use it is when the nurses, we need to get a cath urine, and they come back and say, Seth, I tried, we just couldn't get anything, they're dry. So instead of giving IV fluids and then just hoping and praying that the next time they actually have urine in the bladder, we can actually take the probe, drop it just above the pubic symphysis, and you can see if you've got urine in there. So is it the end all to every problem in the pediatric ED? No. But I definitely use it for early abscess versus cellulitic changes in MRSA skin abscesses. It's easy, I mean, just it's very, very easy to do at the bedside. So, so again, this is just another tool in your toolkit. All right, so let's put all this together, okay? So you got this pink baby that's sick, and you're thinking congenital heart defect. Most likely, this is going to be a heart failure due to a mixing lesion in a child that's well perfused and oxygenated in a 1 to 6 month old age range. Okay, remember I told you the age of presentation is very, very important. They're probably going to be tachypnic, have poor feeding and poor weight gain, have hepatomegaly, murmur, and whiteout on chest x-ray. Your EKG is going to show maybe an AV block or ventricular hypertrophy. Your BNP is going to be increased. And if you look at the x-ray, you're going to have too much pulmonary blood flow and basically too little systemic blood flow. Okay, so this is your overall global problem. Yes, please eat, seriously. So in terms of how we're going to treat these pink babies, so positive pressure ventilation, hypoventilation, and vasodilators. Okay? Now let's move to the gray baby. So this child typically has circulatory collapse, and they are in a left obstructive ductal dependent lesion. They are poorly perfused, and again, age is important. This is in the first few weeks of life. So you will probably see hypotension, tachypnea, a brachial femoral pulse differential, a pulse ox differential, and poor perfusion. Chest x-ray will likely have whiteout as well. So how do you treat these gray babies? So the goal is to increase cardiac activity globally and to minimize O2 consumption. This is where it's critical to go ahead and get the prostaglandin started, because what you want to do is maintain the patency of that PDA, because that's what's been keeping the kid alive to this point. And the reason that they're crashing in your ED is because that's closing. So you want to reverse that if you can. Always think about dopamine or epi, as those will augment inotropy and increase perfusion. All right, so we talked about pink baby, we've talked about gray baby, and let's talk about blue baby. So these are usually, again, this is not all the time hard and fast, but usually this can give you some good information, at least on the outset. This is going to be a right obstructive, ductal dependent, or mixing lesion, and the problem here usually is too little pulmonary blood flow. Again, look at the age. First few weeks of life, they're blue with respiratory distress. They have central cyanosis, usually a murmur, and a black chest x-ray. And EKG might show either early dominant right forces or after that first week of life, dominant left forces. And the BNP likely will not be increased. So when you want to treat these blue babies, you want to think again about prostaglandins, because it's going to increase the flow to the lungs through the PDA. But this is where you do want oxygen, because it's going to cause pulmonary vasodilation. You can add in inhaled nitric and hyperventilation as well. Remember that the systemic vascular resistance can be increased with IV fluids, phenylephrine, and knee to chest positioning. What else? When do you use knee to chest? What's one? TET spells, exactly. How else do you treat TET spells? Who's seen an actual TET spell? Not many. Anybody know how else do you treat? So knee to chest, great. What else? Oxygen and morphine as well. Okay. So I want to briefly talk about when you're talking about treating these kids with congenital heart defects. You always have to talk about QPQS. Has anyone ever heard of QPQS? So QP is pulmonary blood flow, and QS is systemic blood flow. And in all of us in the room, we're pretty much at a 1-to-1 ratio, and you want to shoot for that ratio when you think about treatment. Okay. Because typically there's an imbalance one way or the other, and you want to give something that kind of pulls things back into balance, okay? So when you talk about peripheral vascular resistance and pulmonary vascular resistance and systemic vascular resistance, you want to manipulate these to attain a goal QPQS of a 1-to-1. Okay, that's your overarching goal here. And if the child has had a surgical correction, what you always want to do is ask the parents, hey, listen, I noticed that your child has a median sternotomy. Tell me more about that. I noticed that your child has an oxygen saturation of 78%. Tell me more about that. And they'll probably tell you, yes, my child was born with hypoplastic left heart syndrome. They had a Norwood and a Glenn, and their oxygen levels should live around the 82% range. I'm saying, okay, that makes me feel a whole lot better about the 82%, all right? The reason that this is important is if you rush in like the cavalry and you give a hyperoxia test, you have essentially increased the pulmonary vascular flow by 25 times, and you flooded their lungs. You lose style points for that. Don't do that, okay? All right, so let's quickly talk about intubation. We're finishing up here. Ketamine is usually a great medicine for intubation. It's usually great in respiratory distress and hypotension, but you want to use it cautiously in the critically ill neonate. The reason that this is important in congenital heart defects is that ketamine will increase the systemic vascular resistance, and that will actually increase your left or right shunting, which could make things worse overall. So here you want to consider etomidate. The reason we wanted to at least consider it is because it's more hemodynamically neutral. Now, etomidate has some conflicting press, okay? It depends on which literature you look at. And for us, the more important thing is, are you giving these children single-dose etomidate or multiple doses? There is some conflicting literature, especially in the critical care literature, in terms of the safety of etomidate, and the reason that there's concern about that is adrenal shutdown. But it's one of these situations where you're picking the least of two evils. So at least consider etomidate in terms of your induction, because it is hemodynamically neutral. Once you've taken care of that, you want to paralyze with either ROC or VEC. And remember, this is another thing I want especially the residents to take home. Intubation decreases preload. Okay, let me diverge just for a second. Let's talk about severe asthma. You got a super sick asthmatic that needs to be intubated. Hopefully, you'll never be in this situation. Okay, because intubating a seriously ill asthmatic has an extremely high risk of peri-intubation mortality, and poor Dr. Coy, once you put him up in the ICU, he has a very difficult time getting them off the vent, and a very high chance of having things like tension pneumothoraces while being on the vent. So if you think about our pulmonary physiology right now, I take a breath, my diaphragm pulls down, which causes negative intrathoracic pressure, and because my mouth is open, air goes in. Okay? What do I do when we intubate patients? We flip that around. So we go from negative pressure ventilation to positive pressure ventilation. We put in a hard piece of plastic into the trachea and we force air in. Okay, not natural. It's not what we naturally do now. So if you think about a floppy atrial wall, okay, if that atria and the heart is living in the chest wall, and if there's increased pressure within that chest wall, what's it going to do to the heart? It's going to increase the pressure, right? What does that do to your preload? Okay. So not necessarily in this situation, but you take a sick asthmatic who is already dehydrated, already super sick, and then if I switch them quickly from a negative pressure to a positive pressure ventilation, kids have died just by pushing RSI, period. So if you're concerned in that situation, especially asthmatics, load them up with IV fluids because you want to increase their preload. Now be careful in heart kids, but in asthmatics you want to make sure you increase your preload by increasing your IV fluids. And a lot of times what we'll do in the peri-intubation time is I'll ask my charge nurse, can you pull up 3 doses of push-dose epi? Because the chance of them coding during the intubation attempt is real. It's happened. It definitely happens. So you want to be ahead of the 8 ball and really be able to not have to scurry around and pull up epi when they flatline. You want to be able to really jump in, and hopefully that doesn't happen, but you have to prepare for it. All right, so quickly, we're almost done. Vascular access, either peripheral IV, IO, or a low-lying UV catheter. Now, I'm not a neonatologist, but do remember that the umbilical stump is usually viable for up to the first week after birth. The good thing about low-lying UVs is they're quick, and what I remember is drop a 5 French, 5 centimeters. That's a general rough rule. Basically, you're going into the UV just far enough to where you can get blood to draw back. And this is a resuscitation IV. This isn't we get all sterile and we take time to put it in right. This is one of these lines that we basically resuscitate, and it's going to be replaced once they're in the pediatric ICU. But don't forget about the umbilical stump, because you get a 4-day-old, a 5-day-old, it may be a great option. Okay. If you are out of that age range and the umbilical stump is a no-go, I usually say my frame of thought is about 90 seconds for a peripheral IV attempt. We have amazing nurses in the peds ED that have 30 plus years of IV start skills. And if they look at me after 90 seconds and said, Seth, this is a no-go, we stop there, I drill the leg, okay? IO, I can have fluids infusing within about 30 seconds from start to finish. It's super fast and it can be life-saving. Now we're going to end with prostaglandin. So remember that prostaglandin, also known as PGE1, stimulates ductal endothelium and maintains patency of the ductus arteriosus. Should be implemented for any neonate with hemodynamic collapse or cyanosis in the first month of life. And remember that the ductus typically closes by about 72 hours. But if you have a pathologic heart lesion and flow depends on the ductus, it could take longer to close. So anytime within that first month, it has to be kind of your time frame as well. So it's great for those blue babies and the gray babies that we talked about that usually present early. There's no real harm in starting prostaglandins, even if it's not a cardiac baby. But I will tell you one exception to that is if you have an infradiaphragmatic TAP VR with obstruction. Dr. Teixeira, have you seen many of those? Have you? Okay, gotcha.
The only thing I have to say is that I've thought a lot about these problems, and I don't see any exception to that reflected or not.
Gotcha. Thank you for that.
Because you bring the baby back into the state.
Right.
Whatever you do, what they want, you return the baby to the state, and all of the then are non-exactly.
Excellent. Thank you. All right. If you want to get up with a microscope, here's my references. I want to say a huge thank you to Dr. Anand for reviewing this presentation for accuracy. Unfortunately, she's out of town and couldn't be here. So, questions at all?
Brown, if you get a call from an outside hospital or ER that's an hour or 2 hours away and it sounds cardiac to me, would you recommend starting prostaglandin prior to evaluation? All our referral hospitals I know would make sure they have it in stock.
Yes. And I would probably go back to Dr. Teixeira's comment in terms of if the history and physical is leaning in that direction, I would say yes, with the caveat of understanding that you can have apnea and more than likely you're going to need to intubate the child. So let them definitely prepare for that prior to. But I would say yes if we were serious. Again, this is going back to the Misfits mnemonic. You think, you're probably 90% sure this is a congenital heart defect, but there are a lot of other issues that could be going on. So in addition to prosta, these kids are going to get IV antibiotics and those types of things because you're wanting to save a life quickly, basically. So my answer to that would be yes. Great question, though, Dr. Bell. Do you have anything else to add about the 2006 Tennessee Task Force? I thought that was really cool that you were involved in that because this is
Just a brief history, and some of you were here then, but on the State Perinatal Commission and our center here got volunteered to do a pilot study for the Department of Health looking at kind of a cost-value analysis of implementing a 100% newborn screening protocol. What they wanted us to do is look at what the cost was for the procedure, what the time commitment was. They asked us to develop nursing education protocols cost per screening is about $2. The screening test results are all recorded on the state PKU slip. There's actually a checkbox on there now for saturation. So it's monitored very closely by the Department of Health. And actually the nursing education protocols that we put in place here were used by the CDC and disseminated to other states for use.
And can you remind the residents why you don't do the pulse ox test within the first 24 hours?
Within the first 24 hours, we talked a little bit about flow changes, but we still, in some babies, can have systemic pressures that remain a little bit low and pulmonary pressures that are a little bit high, and usually by 24 hours, they're in the correct alignment with systemic being higher than pulmonary. That's probably the main reason.
One thing I have to say is that in echo-any business, how do you recall any false positive that we've seen at all?
Wow,
So extremely well done job.
that's awesome.
False positive is a big concern with the health department. If you're a small rural hospital, you fail the test, you're looking at a several $1,000 transfer to a place where you can get a cardiac cardiologist. So that's one of the major things that the state is interested in, is what it might cost them to get a high false positivity.
I see Dr. Hunter's name there, and he's out of time. Just my contribution.
Yeah, please.
In terms of timing, you stress a lot timing, and I stress further. If you look at the first week in first week, cyanotic first week, transfusion, acyanotic, hypoxia. Second week, 1 month, acyanotic, cyanotic, so if you look at 1 week and 1 month, you pretty much have an idea.
That's great.
The other thing that you stress, the feelings of equality, I say this because sometimes you see in the pediatric radiology talking about not being necessary in a neonatal period. What it is you did say, so you cannot rule out until the heart defect is abnormal. On the other hand, if you're having a normal one, you strongly can make the diagnosis. And we have had the opportunity of helping our local pediatric radiologists that normally can feel coming up with a diagnosis based on EKG. So, if it is abnormal, it helps you tremendously to guide towards what you expect to see.
Gotcha. Great. Thank you. Excellent points. Any other questions at all? All right, guys. Thank you.